Thanks for all coming. My topic today is recurrent urinary tract infections in women and the role of the urologist. Start by going over some objectives, define the different types of UTI we all know, review the relevant clinical guidelines from the CUA and EAU for recurrent uncomplicated UTI, explore emerging conservative treatments for recurrent UTI, and review the local antibiotic resistance patterns. So why UTIs? No rounds on this subject since 2001, but it is a very common referral with wide variability in practice pattern, and the expectation that we are experts in this area. But before we proceed, now is a great time to put your cell phone and pager on vibrate, and for our Uro-oncologist to power up your laptops. So let's look at a typical referral. Dear VGH locum, urologist, please review this frustrated, otherwise healthy 28-year-old female, Miss Laura Jones, who in the last 5 years has had 5 documented lower urinary tract infections, each treated with a course of antibiotics. Attached are relevant investigations and culture results. So UTI Refresher, they're extremely common, affecting 1/3 of women by the age of 24. And alone in the US, it costs $3.5 billion a year to treat urinary tract infections. They're ascending bacterial infections from the periurethral region, causing cystitis and pyelonephritis. And the key uropathogens, as we know, is E. coli, roughly 2/3 of UTIs, Klebsiella, Staph saprophyticus, Proteus, and Enterococcus. And it's these virulence factors of these uropathogens that allow improved adherence, infection, and colonization. So let's look at E. coli more in depth, specifically the adherence mechanisms. The type 1 pili and pyelonephritis pili, or fimbriae, are essential for adhering to the uroepithelium, colonizing the bladder or kidney, invasion, and persistence. And it's these adherence mechanisms that may be targets for preventing UTI down the road. We all know these definitions, just to review. So a UTI is defined as a positive culture in a patient that's symptomatic, ideally midstream, and 1 × 10⁵ colony-forming units per liter. In EAU, they define as 1 × 10⁵. They're either uncomplicated or complicated. Uncomplicated occurs in a healthy host with no structural functional abnormalities of the urinary tract. Complicated is everything else. And recurrence is follows a complete clinical resolution of previous UTIs, 3 or more in 1 year, or some people define it as 2 in 6 months. And the type of recurrent UTIs are either persistence or reinfection. Persistence are less common, same bacteria still present after 2 weeks of appropriate antibiotics. So you should raise some red flags. And the more common is the reinfection, a different bacteria after 2 weeks of appropriate antibiotics, or 2 weeks after an appropriate course, or a negative culture in between. Let's look at the breakdown of these uropathogens and what they call as uncomplicated or complicated UTIs. Obviously, the key player is E. coli, causing 75% of uncomplicated and 65% of complicated. The risk factors for uncomplicated are female gender, older age, younger age. And if you look at the risk factors for complicated, indwelling catheters, immunosuppression, urinary tract abnormalities, and antibiotic exposure, the profile of the bugs involved are a bit different.
Sorry, she didn't get that. Sorry.
You looked at Enterococcus in the complicated UTI goes up, and that may be affecting those immunosuppressed as well as the candidal infections. So just to go over this again, this is the CUA guidelines and their risk factors for uncomplicated recurrent UTI: menopause, obviously female gender, family history, sexual activity, new sexual partner. use of spermicides, and recent antimicrobial use. And I think the role of the urologist is to tease out, who is uncomplicated and who is complicated, because these potentially have a reversible cause. Any anatomic abnormality, we're taught to look for a urethral diverticulum on exam, iatrogenic causes, indwelling Foley, hospital infection, and recent surgery, voiding dysfunction, reflux, neurological disease, pelvic floor dysfunction, high post-void residual, incontinence, urinary tract obstruction, either at the bladder outlet or in the ureter, or other. Pregnancy would make, even though they're healthy hosts, they make it complicated. Urolithiasis, diabetes, and other immunosuppression. And these are all pretty much ruled out on history and physical, or suggest high risk factors for further investigation. So let's meet Miss Jones, our kind referral from the GP, who has a history of UTI, the common symptoms when she's experiencing a UTI: urinary frequency, urgency, dysuria, no fevers, occasional hematuria. Once following coitus with her partner, she can sense when the UTI is coming, but symptoms do resolve with antibiotics. She voids typically every 2 to 3 hours, is not constipated, has regular bowel pattern, and no incontinence. But her mother also had the same problem. But she herself, this is pretty new for her, nothing in childhood. On physical, her abdomen is soft, non-tender, normal pelvic examination. He attaches some culture results: E. coli ×3, Klebsiella ×2. They're all pan-sensitive, so no resistance. And an abdominal ultrasound was normal, done by the GP. So your impression early on is that, this patient's pretty uncomplicated, a young, healthy female with no risk factors, it seems. But, she's frustrated. There must be something wrong with me. Can't you figure it out? So, you being the locum urologist, or just not wanting to miss anything, you say, maybe I could look in the bladder. And you see this, it's normal. And you tell her, this is, you got a normal looking bladder, and she's not too happy about that. So she wants you to look harder. You don't look again. You just go to literature and see if any other people have done this before you. Cystoscopy in women with recurrent UTIs, so that sounds about right. Study done out of Australia. Retrospective, they looked at 118 women who all had cystos, mean age 55, and they only found 9 abnormalities, 6 of them being urethral stricture, which is a controversial, rare entity, and there's no role for, or no evidence for even treating these findings: bladder calculus, bladder diverticulum, and colovesical fistula. So if you look at it further, they summarized other studies that looked at cysto in recurrent UTIs, and the range is between 0 and 14%. So again, it may be a low yield, low probability study. And they concluded that, in imaging, or they noticed that with imaging, a negative or normal imaging predicted a normal cystoscopy. And those patients under 50 with a positive cysto had significant risk factors. So they concluded that women without risk factors for recurrent UTI and with normal imaging could have a cysto omitted. And younger women are less likely to have pathology, and this must be factored into decisions to perform cystoscopy. And I think these take-home messages are in keeping with the EAU and CUA guidelines. I'll go over it, but ultrasound or CT-IVP. So who should get additional investigations? Who should spawn, red flags? So prior urinary tract surgery. These are really the risk factors for complicated UTI. Gross hematuria after resolution of infection, so an underlying malignancy possibly. Previous bladder renal calculi, maybe a nidus for recurrent UTIs. Obstructive symptoms, maybe leading to retained urine and urinary stasis. Urea splitting bacteria on culture, so Any Proteus positive culture should alarm the urologist that maybe there are stones either in the bladder or in the kidney. Bacterial persistence after sensitive-based therapy. Maybe the antibiotics aren't being delivered or there's not enough flow to clear the infection. Prior abdominal pelvic malignancy, diabetes or otherwise immunocompromised. Maybe they don't have the immune system to fight off these bacteria. Signs and symptoms of possible colovesical fistula, risk factors being diverticulitis, repeated pyelonephritis, so fever, chills, vomiting, CVA tenderness, and asymptomatic microhematuria after the resolution of a symptomatic UTI. These are the CUA recommendations, and these are the red flags that we have to pick up on history, and sometimes these questions haven't been asked by the primary caregivers. So they CUA recommends PVR only in postmenopausal women. In premenopausal women, high PVRs weren't associated with increased UTI. Cystoscopy, they say it's unnecessary in uncomplicated UTI, given the data I presented. It's just low yield. Imaging, only if high clinical suspicion. No role in uncomplicated UTI, and CT with contrast is the gold standard, but ultrasound with our patient is the most common. So you've made the diagnosis, and how do we manage these patients that are coming to our clinic? So no good evidence exists for conservative measures, such as good hygiene, wiping front to back, but it's reasonable to recommend them as they're thought to be harmless. Ensure adequate fluid intake, regular voiding and stooling, proper hygiene. These are all reasonable, healthy advice, but there's just not strong data to support it. Pelvic floor physio for dysfunctional voiders has some good feedback, and voiding before or after coitus, no evidence for this practice. So the CUA recommends this as it's low stakes, but not a lot of good evidence to support it. And what about probiotics? There's evidence to suggest that lactobacillus does prevent UTIs, restoring healthy flora in the vaginal area. One phase 2 trial had positive results with intravaginal suppository. So we'll see if that becomes an available treatment. Cranberry products to prevent UTI is conflicting, and no recommendation can be made for or against their use.
The phase 2 trial, is that a single arm? Is it randomized?
I didn't.
Or it's compared to placebo?
Yeah, to placebo.
Are you? Then we're going to talk. These are from 2011, right? For cranberry, there is an additional 3 studies since then.
Yep.
You get it.
Yep. So I've started because it's controversial. I just thought I'd look back at the, why are people talking about cranberries? So as the Coli Virulence, type 1 pili and P. pili, maybe blocking those receptors may prevent the adherence of the bacterium to the uroepithelium. So the theory is that fructose in the cranberries work to inhibit the adherence of type 1 pili that cause cystitis, and the proanthocyanidins, or PAC, inhibit the adherence of P. pili. And if you decrease this adherence, it leads to decreased colonization and invasion. So Lynn Stothers did a study in 2002, 3 arms for 12 months, randomized women with recurrent UTI, and they were sexually active, to cranberry juice. They had to have 3 cups of it per day, cranberry tablets, and placebo. Each who got the active juice got a placebo tablet. Active tablet got a placebo juice, and some patients got a placebo juice and tablet. Their endpoints were a greater than 50% decrease in symptomatic UTI and 50% decrease in annual antibiotic consumption. They also did a cost analysis looking at the money saved on prophylaxis versus money cost to per UTI. So it was a positive study suggesting that cranberry juice and cranberry tablets had decreased number of patients experiencing at least one UTI versus placebo. The cranberry tablets were most cost effective, about $600 a year, and cranberry juice were the least compliant. It's 3 glasses of juice every day, and in 5 of the months out of 12, they had less than 80% compliance. So maybe it works in theory, but if women aren't drinking the juice, then it may not be as effective.
So the primary endpoint was a greater than 50%?
Mm-hmm, because everyone had at least 2. So if it could get down to 1 or less, then it would be greater than 50%.
But what's the 20 and 18%? Is that a risk reduction you're talking about?
Exactly, yeah. Because they all came in with 100% having at least 2 in the last year.
If you need a primary endpoint, you'd have to have a risk reduction of 0.5 or greater.
Mm-hmm.
There it's 0.2.
It's not 50%. Whatever the endpoint is. The endpoint is a decrease in UTI is about 50%, from 2 to 1 to 2.
Yeah.
So I was thinking something.
So this was one of the first trials, but there's been many more since. I found this review in the Archives of Internal Medicine in July of 2012, looking at 10 RCTs, cranberry-containing products versus placebo or non-placebo. They excluded one study, as it was an outlier study, and there was moderate heterogeneity of the data. Look at the forest plot here, showing a risk ratio of 0.62, but heterogeneity of 43%. So there is wide variability in giving cranberry products and the results you get. They did a subgroup analysis showing risk ratio of 0.53 for women with recurrent UTI, so these would be the population we're after. Female population in general for 0.49, and using cranberry-containing products more than twice daily. The theory that cranberry hangs around for about 8 hours, so there may be some benefit for TID or even more dosing. But I guess this, was definitive. The 4th revision of the Cochrane collaboration for cranberries for preventing UTIs. This came out later that year in 2012. They had 24 RCTs with 4,400 patients looking at cranberry juice, cranberry tablets, juice or tablets or capsules. And they found that cranberry products did not significantly reduce the occurrence of symptomatic UTI, with it crossing to 1.04. Risk women with UTI to 1.31, so not significant. And they noted that all these studies had low compliance, high withdrawal, dropout problems, specifically with the juice that we talked about, and that the tablet and powder composition of the cranberry products, weren't the active ingredient wasn't provided. It was just it wasn't controlled. So they concluded that cranberry juice specifically cannot be currently recommended. Other preparations need to be standardized and investigated accordingly before recommended for use. And they, provide that there's very little benefit for high dropouts, poor compliance. What about other conservative measures? There's a OM89, a couple trials in Europe, and this is the EAU guideline saying it's more effective than placebo. I'll get into this later. D-mannose, so it's a structure that can be taken orally and adhere to the type 1 pili and possibly prevent the adherence of this bacterium. And it was equal to nitrofurantoin and superior to placebo. And then endovesical installation of hyaluronic acid and chondroitin sulfate to replenish the glycosaminoglycan layer in the bladder, because this is a theory that maybe this layer is deficient, and that's how the bacterium are adhering and invading and causing UTIs. So this is the study that I found out of European Urology, RCT, women with recurrent UTIs, 230 in the active group receiving Urovaxum, or this 6 milligrams of lyophilized lysate of E. coli, and placebo group, where they received 1 capsule per day for 90 days, a 3-month washout treatment. Then the first 10 days they called it a booster period, where they received 10 days of the capsule for the first 10 days of each month, 7, 8, and 9, and then 3 months of washout. If you look at the figure here, they had significantly more patients staying UTI-free when they all, at baseline, get recurrent UTIs, and they had less number of UTIs in the period of observation than placebo. What about D-mannose? It's been around for ages, and the theories have been around that it may prevent UTI by binding the type 1 pili and preventing adherence. They did an RCT in 2014, the first, they said, and they looked at 100 women in each arm, comparing 2 grams of D-mannose, and they obtained the D-mannose from a lab in America that it's branded Utract in 200 cc's of water, macrobid 50 milligrams daily, which is the gold standard, and no prophylaxis for 6 months. The primary endpoint being number of patients in each group without recurrent UTI after 6 months. So if they became symptomatic and had a UTI, they would be treated and come off prophylaxis.
How's it given? 2 grams and 300 cc's? Or?
Yeah. So it's just at night you have a glass of this with 2 grams, and it's about $30 for the 50 grams, and so it covers about 25 days of it. So about a month worth, $30. So this is a nice plot of their results, and that 80% of women at the end of the 6-month period did not have UTI, whereas 40% on placebo did. So it was a positive result for not only D-mannose and nitrofurantoin compared to placebo, but D-mannose had significantly lower risk of side effects compared to nitrofurantoin, and maybe not clinically significant, but nitrofurantoin typically is very well tolerated, so they decided to mention this. So there's conservative measures, and then there's antibiotic prophylaxis, and with antibiotics resistance, this prophylaxis is good for how long? Because we're very worried subjecting these young women to lots of antibiotics, and maybe down the line it may affect their health, that they're just so resistant that no antibiotics will be of benefit.
One thing that you mentioned is the rare but significant issue of other system problems with, I think,
respiratory, yeah. They do in the guidelines, they do mention that, and they caution the healthcare provider that there's significant concern about macrobid for that very. Mm-hmm. So
it's not removed.
So the CUA, says that all conservative measures should be exhausted before going down this line of treatment. They provide the continuous low dose for 3 to 6 months. Allergies, prior susceptibility, local resistance patterns, costs, and side effects should be determined the antibiotic's choice. So they didn't recommend anyone in particular, but provide a list. post-coital. So if the history is very convincing that this young woman is getting UTIs typically after partaking in coitus, then this shows equal efficacy to continuous low dose. And a self-start, when these women recognize UTI symptomatically and start a 3-day course of antibiotics, 5 days for macrobid. There's good concordance between them feeling like a UTI is coming on. About 90% they're correct in that they will have a positive urine culture, and they're advised that after 48 hours, if their symptoms haven't resolved on their self-start regimen, that they contact their healthcare provider. So CUA lists these regimens. You've got the Ceftra, Cipro, the cephalosporins, and macrobid. And it's a similar dosing to the postcoital, and generally lower dosing than your full dose. So looking at the VGH antibiogram, we know that resistance is on the rise. I'll point out with the red circle there, E. coli, with 75% resistance to Cipro, and that's just sensitivity. So 25% resistance, and we've been using a lot of amoxiclav for these patients, and it's 21% resistance, and in this year the ESBL was 13%, as indicated through the Ceftriaxone. And it also highlights that the cephalosporins have no activity against Enterococcus. And if you're thinking about prophylaxis for these women, good coverage against E. coli and in simple cystitis, but no activity against Proteus, and poor coverage of other bugs. So if they're failing treatment or getting breakthrough infections, it may be these other bacteria that are causing the infections. And we all think that everyone's more complex at VGH, or they have these super bugs, but similar antibiograms at Richmond showing about 23% resistance to Cipro, and the similar resistance patterns to macrobid and Ceftra. So how did we get here? When Cipro had about 3% resistance in 1999, and we're up to as high as 27% in 2011. So there is great concern over resistance, shown nicely in this plot, that it's become a problem definitely in our lifetime. It already is. And the elderly are more resistant, showing that if you're in your 70s, you've got over 30% resistance to Cipro, and these are the trends published by the Center for Disease Control. So is Cipro a good option? If you're thinking E. coli or UTI, and Dr. Black showed that in the rectal flora, these men even have up to 20% resistance to E. coli. And then ESBL over the years, it's increased dramatically since 2002, and in the last year it was 13%. So we're taught, start AMP and Ceftriaxone for Urosepsis, or AMP and Gent. So the AMP covers your Enterococcus, and Ceftriaxone in theory covers your gram negatives, but if you're going to be missing 13% of the bugs, and they're very, very sick, what do you do? So it's promoting a lot more, thought as to what our sepsis guidelines will be. Piptazo and the carbapenems still have good activity against E. coli.
Ben, on that note, in a prosopapsy one, essentially no resistance to piptazo and no resistance to treatment. So
Yeah.
those would certainly be the first choice.
Yeah, exactly.
Post-biopsy.
Thanks for
Yeah, exactly. So if first line then becomes Miro or imipenem, then maybe we're talking about the same problem in 10 years from now. That we had great success early on with Ceftriaxone, but now we're and they are working on it's a very active field. Beta lactamase inhibitors plus one of these agents, they're combination therapy to save these antibiotics. So back to Miss Jones. She's interested in trying D-mannose. She has 2 UTIs in the next year, both E. coli, and she's pretty sure they're both following coitus. So she's prescribed macrobid, PRN, within 2 hours of her coitus. And what happens to her? Well, your locum ends, but she feels that she's ready to go back to the GP. She has strategies in place to decrease the frequency of her UTIs. So in summary, behavior advice, it's thought to be harmless, but no strong evidence in the literature to support there of any benefit. I briefly went through the non-antibiotic prophylaxis that I think is growing in research. There are E. coli vaccines in the literature that hopefully boosts your immunity to fighting off UTIs for those with recurrent UTIs, and the risks of the antibiotics prophylaxis route. But at the end of the day, this is maybe the only thing that these patients have to rely on. So that concludes my talk. Thank you.